Good morning. We're going to get started. It is my pleasure to introduce to all of you Dr. David Owens, who many of you know well. And I will simply say he carries many titles that I'm going to now describe to you from order of least to most importance, because the last one is, he just told me, consultant to the Seahawks. So you can put everything else in context for that. But he is the co-director of our cardiac genetics clinic. He is the associate director of sports cardiology at the University of Washington, as well as the director for hypertrophic cardiomyopathy here. So without further ado, it is my pleasure to introduce Dr. David Owens.
Great, thank you very much. So I hope this is a little more approachable and entertaining topic. I decided not to talk about hypertrophic cardiomyopathy, which is what I expect. I thought everybody was going to do, partly because Fareed gave his talk recently on sarcomeric mutations, and secondly, I think Steve Amman is coming as a visiting professor later this year, so I think he's going to talk. So I'm going to do something a little bit different, and we're going to talk about sports cardiology, which is an area of interest and something I've been getting more and more involved with as we go forward. So first off, let's see if we can advance the slides here. No disclosures relevant to this talk. And we'll talk about sports cardiology as a field. So the number of individuals, we're sort of in a country right now that's dichotomizing. We're getting a little bit more obese, more sedentary, but then there's certainly a subset of the population that is getting more active as well. We've seen an increase in the number of professional and intercollegiate athletes. We've seen an increase in the number of people participating in marathons, triathlons, ultramarathons, that kinds of things. We're also seeing an increase in the number of older individuals who are participating in these types of events. Sports cardiology, therefore, has emerged over the last, I'd say, 5 to 10 years as an entity to respond to the unique challenges and desires that this patient population presents. And so in 2011, the American College of Cardiology started their sports and exercise section and have been fortunate enough to be able to participate on the editorial board for the website, and we do content production for that. Let's see here, and here's the website right here. We've been having annual meetings. These are usually held in a nice location of Park City, Utah, where we talk about care of the athletic heart. And then finally, in about 2014, we started the Center for Sports Cardiology here at the University of Washington. And that is a joint sort of effort between our sports medicine colleagues, a number of whom have a specific interest in this topic, sports cardiology, and ourselves. And so, in last year, then there's no board certification for sports cardiology. There's no test that you have to take. But there's a sort of a guidelines for core curriculum and the types of things that people who practice in this area should be knowledgeable about and responsible for. And they divide that into 4 major categories. The differentiation of exercise-induced cardiac remodeling from cardiovascular pathology, that's a big part of what we do. The evaluation of a symptomatic athlete, management of athletes with cardiovascular disease, and lastly, prevention and screening for sudden cardiac death. And this is an area actually that the University of Washington is known for nationally, and perhaps internationally as well. And we'll go over some of the research that the University of Washington has been able to provide. So what is an athlete? Definition of an athlete here, this is taken from the eligibility and disqualification recommendations chaired by Barry Marin. And it defines an athlete as one who participates in an organized team or individual sport that requires competition against others as a central component, places a high premium on excellence and achievement, and requires some form of systematic and often intense training. I have one sort of argument with this definition, and that is I think a lot of the athletes that we see aren't necessarily competing against others. They're competing against themselves, trying to perform, get PRs and things like that. Secondly, is that one of the introductory concepts I want to introduce here is this categorization of sports. And this is sort of the classic categorization and dividing sports into how much static activity is and how much dynamic activity is going on. So we think of static activity as strength-based activities. So weightlifting up here is one of the primary examples of a static exercise, and then dynamic exercise, which is more of our aerobic type of conditioning that they see here. I don't know that this is perfect, but it gives a sort of an introduction as to how we might go about thinking about some of these sports. We also, when dealing with this patient population, have to recognize the extremes in body morphologies that we encounter. And so the people who participate in some of these sports are some of the largest individuals in the country. And we have to be able to recognize some of the things, and the chamber sizes especially, that may be different in those athletes. So here we have LeBron James, who actually looks small in this picture, which is just incredible to me. And here's Shaquille O'Neal. And then athletes over here can be on the small side, and then our sort of recreational athletes here in the middle. So first off, I'm going to talk about this concept of exercise-induced cardiac remodeling and how we may use this to sort of interpret the test results in our population. So what determines cardiovascular fitness? Cardiovascular fitness is really determined by our oxygen utilization through the body. That involves oxygen absorption through the lungs, the delivery of that from the lungs to the skeletal muscles, uptake of that oxygen peripherally, and then the use of that oxygen in skeletal muscle metabolism. Turns out that the largest determinant of fitness is actually the oxygen delivery. It is our ability to increase cardiac output. And what separates the untrained athlete from the trained athlete is the ability to augment this. So at rest, our cardiac output is generally in the range of 5 to 7 liters per minute. When you get up and exercise, we can increase that by 3 to 4-fold. And that gets up to about 20 to 25 liters per minute. By the time we get to be a trained athlete, we're dealing with cardiac outputs at peak exercise that reach approximately 40 liters per minute, which is very large. So the gains that we see during early exercise are probably unrelated to oxygen delivery. They're probably more related to improved oxygen uptake and metabolism. That has to do with things with changes in capillary density, myocardial density at the skeletal muscle level, change in the oxidative fiber types of the skeletal muscle, and increase in the muscle mass, all of which can increase the oxygen uptake and utilization. But it's this other part here, the later gains that are largely due to cardiac remodeling, that allows the real improvements in cardiac fitness. This takes months to years to occur. And so if you go out and you start training and you've been running for a month, most of the gains that you experience are going to be due to the changes in oxygen uptake metabolism. And this part, the changes in cardiac remodeling, take a long time. So this idea of cardiac adaptation to exercise is sort of common. It's sort of the core principle of sports cardiology. The idea is that individuals who engage in endurance exercise have eccentric remodeling, and they dilate their heart. And those individuals who engage in strength-based activities have concentric hypertrophy and develop more left ventricular hypertrophy. This concept is called the Morgenroth hypothesis. This arm of it, especially down here, has been called into question based on some MRI studies. It's clear, though, that the aerobic activity can lead to improvements in stroke volume and cardiac adaptation, largely due to changes in chamber diameters. And so this is, I think, the most elegant example of that. This is done by Ben Levine, who's one of the best cardiac physiologists. He's down in Texas. And he looked at just 12 sedentary subjects, but looked at them very intensively. They're age 29. They embarked on a year-long marathon training program. This is a training intensity over here. So as time goes by, they're increasing their intensity of exercise. And the activities that they do is predominantly aerobic. What they did with this is they did serial CPATs, cardiac MRIs, and they did PA catheterizations both pre and post this exercise regimen. These individuals increased their peak oxygen, their peak VO2 here by about 20%, from 40 to about 49 milliliters per kilogram per minute over that 1 year of exercise. What we see with this in terms of the chamber diameters is we see a gradual increase in both the left ventricular end diastolic volume and right ventricular end diastolic volume over time. The changes in right ventricular volume occur a little bit earlier than the changes in the left ventricular end diastolic volume. And this actually goes along with some data from the MESA study suggesting that moderate levels of exercise can actually start to dilate your right ventricle before we see much changes in the left ventricle. When you look at the wall thickness over here, we see a small increase in the left ventricular septal diameter, basically along with that, and then it looks like it sort of plateaus. So this idea of cardiac remodeling, we talked a little bit about the structural remodeling that occurs, the chamber diameter. It occurs in all 4 chambers of the heart. It occurs in the more compliant chambers the most, so the right ventricle, right atrium, left atrium, dilate a little bit more than the left ventricle itself. But the IVC also dilates. I put up here that this is 5-chamber dilation because we also have to remember that the IVC has experienced the same sort of increase in volumetric flow, and you'll see the IVC dilate. That has implications for how we interpret central venous pressure in athletes. I've had at least one referral for somebody who was deemed to be in heart failure because they had a big IVC. In fact, the patient was a high-performing athlete. The exercise not only changes the volumes of the heart, but it also improves the ventricular compliance. I'll talk about that a little bit more. It improves stroke volume reserves, and with this, we have an improvement in contractile efficiency. With the left ventricular dilation, an improvement in the compliance, what we get is more of a reliance on the Starling forces to improve stroke volume, and less of a reliance on contractility, and that is a little more energy efficient, and so we're improving the efficiency of the contraction and cardiac output as well. Along with the structural remodeling, we also have electrical remodeling that goes on. And this is largely due to increase in vagal tone. And on an EKG, we'll see resting bradycardia, but we'll also see various forms of heart block. We'll see long PR, first-degree heart block. We'll see some pauses, very long RR intervals. We might see Winky Bach. Ectopic atrial rhythms are very common in this population. All of this is normal physiology and not to be overly concerning. A couple of examples of this. There's a former UW basketball player here who's now a professional basketball player who's had a PR interval on his resting EKG of somewhere around 520 milliseconds. So that was quite impressive when we saw that the first time. And then I've had a marathon runner who engages about 8 to 10 marathons a year who, for her FAA pilot's license, needed to have a Holter monitor performed. And on that, she had 8-second pauses during sleep. And our answer to that was not to do Holter monitoring anymore, rather than to so all of that occurs as a result of this electrical remodeling, and then it allows us to increase our heart rate reserves, and that's another way for us to augment our cardiac output with for athletes. There's a lot that goes into this process. Exercise, the type of exercise they do, the duration of exercise, how long they've been doing it, the intensity and frequency of exercise all play a role in this process. Age of the athlete, sex of the athlete, race and ethnicity of the athlete, and there's probably some genetic contributions as well that haven't been teased out all that much. And so the real aspect and sort of the art of this sports medicine is in understanding the dose-response relationship between the types of exercise that is being performed and the chamber dilation that we're seeing. And so here's an example of a couple of athletes. This gentleman over here is a UW runner, a cross-country athlete. He can run 5-minute miles for something like 10 miles at a time. His left ventricular end diastolic volume is severely enlarged. Upper limits of normal is about 75. We call it severe when it gets to be about 95 milliliters per meter squared. So that's just a huge left ventricle based on his body size. This is actually one of the Seahawk players with this very large right ventricle, all of which I think is normal response to the exercise training that those individuals have done. We see some of this in our Tour de France athletes as well. And this is on the x-axis down here, we're looking at left ventricular internal diameter, and over here we're looking at ejection fraction. And so what I've done here is just highlighted a couple of things. All of these athletes here, shown in red, have dilated left ventricles. Some of them have left ventricles that are 7 centimeters or greater, which is very large even for somebody with a dilated cardiomyopathy. And secondly, a large number of these are not I'd say a minority, but a substantial minority, have ejection fractions that are in the low normal range. So here's 55%, that's our lab's cutoff for ejection fraction. All of these individuals have low ejection fractions by our laboratory, but they have normal overall stroke volume, normal resting cardiac output, and they can augment their cardiac output substantially. So all of this is normal physiology, and this is not somebody, even though a dilated heart with a low ejection fraction creates a condition that you might be concerned about dilated cardiomyopathy. This is all normal physiology. We'll also turn and look at wall thickness in athletes, and this differs a little bit based on race and sex. I'm showing here a distribution of left ventricular wall thickness. This is septal wall thickness in male athletes, both white and black, and in female athletes on the right, both white and black. And 2 points here. First is that males have a greater wall thickness on average than females, and then secondly, black athletes have about 1 to 2 millimeter greater wall thickness on average than female athletes do. And that's actually not just for athletes, that's pretty much for everybody. When we look at the NFL Combine data, we can look at the wall thickness a little bit more. And this, I brought this up to look at not only the effects of exercise on wall thickness, but also the body size aspect of things. These are very large individuals. And we look at this, the percentile here, the 50th percentile of septal wall thickness and posterior wall thickness is really at the upper limits of normal. So right in here. We look at the number of athletes that have what we would consider to be abnormal wall thickness. We're dealing with somewhere between 40 to 70% of the NFL athletes have wall thicknesses that are considered to be abnormal by our laboratory measures. When we look at aortic sizes in NBA athletes, we see that they're surprisingly not as abnormal as we might expect. Endurance exercise increases aortic size by about 1 to 2 millimeters on average. But you look at the aortic root diameter here and the distribution of the aortic root diameters among these NBA athletes, our laboratory cutoffs is about 35 millimeters here. About a third of them have aortic root diameters that are a little bit enlarged. But when you look at the distribution here based on height and body surface area, there's very few of them that are actually up here in this range, and they tend to be the largest individuals. So certainly large individuals do have bigger aortas, but it's not as pronounced or surprising as it might seem. There are some NBA athletes who are gene positive for Marfan syndrome, and they probably represent some of these individuals over here. Before I go on to the next topic, I want to take a little bit of a diversion and talk about this idea that exercise-induced cardiac remodeling can sort of prevent heart failure in the future. So we know that sedentary aging can lead to smaller left ventricular chamber sizes and reduced left ventricular compliance, all of which sets up the individual for heart failure with preserved ejection fraction. Competitive masters athletes have larger, more compliant left ventricles. Exercise training over a lifetime can counteract the detrimental effects of aging and inactivity. And epidemiologic studies suggest that midlife fitness is a strong predictor of future heart failure events, all of which brings up the idea that the epidemic of heart failure with preserved ejection fraction may be in part a consequence of inactivity. So can we modulate that by getting people to exercise a little bit more? This is another study by Ben Levine. This is a sort of intense sort of a look at the physiology. They randomized about 61 individuals to aerobic activity versus a flexibility or balance training program. Both of these had sort of a graduated programs. These were healthy individuals. They excluded everybody with hypertension and coronary disease. We had 5 dropouts in the exercise arm, 3 dropouts in the flexibility and balance arm, 88% compliance with exercise, and they looked at CPET measures, echo, and PA catheter measures. When we looked at this, I should say in here the average age of these individuals was 52 years. We're dealing with midlife individuals. So Up here, when we look at function, on the left here is the flexibility and balance group. They saw no improvement in their overall aerobic fitness, whereas the people assigned to the exercise group did improve their exercise capacity. This has shown that they were able to dilate their left ventricles in response to exercise, as we might expect. But this is the important slide I wanted to point out, and that is when we look at the left ventricular compliance measured invasively as the relationship between pressure and volume, we see the shift in the curve to the right and downward, which suggests improvement in left ventricular end diastolic compliance with exercise. And so this idea that even in midlife, exercise can not only enhance your cardiac output by changing the chamber size, we can actually improve the performance of the ventricle and improve the compliance of the ventricle as well, all of which argues that exercise, even in midlife, may be a way of forestalling heart failure with preserved ejection fraction. So I want to switch just a little bit and talk about screening and prevention of sudden cardiac death. This is an area, like I mentioned, that University of Washington, I think, has made some contributions to, and I wanted to sort of point out some of the contributions of our colleagues. So sudden cardiac arrest in youth, sudden cardiac arrest in general, as we all know, abrupt and sudden loss of heart function, usually due to abnormal heart rhythms. The incidence in sudden cardiac arrest in youth and athletes is rare, fortunately, but estimates vary widely. There's about a about 25-fold difference in estimates. It's very difficult because the case capture is challenging. There's no mandatory registry. There are some efforts to systemize this, and there's an NIH-sponsored sudden cardiac death registry that incorporates about eight metropolitan areas or counties within the U.S. to try to capture that. Survival from sudden cardiac arrest, as you know, remains low overall. There's been a big push to provide AEDs at the site of sporting competitions, and that hopefully has improved the response rate to sudden cardiac arrest. We know that exercise increases the risk of sudden cardiac arrest overall. This is in all individuals and in athletes as well. This is data that goes back about 18 years. This is David Siskovic here from the University of Washington. And when he looked at the physician health study, showed that the relative risk of sudden cardiac arrest during an active period of exercise or immediately following exercise was 17-fold higher than at rest. So every time we get up and exercise, we are at some increased risk of sudden cardiac arrest. It's modulated by the frequency of exercise. So risk of exercise, sudden cardiac arrest by frequency of exercise here. Those habitual exercisers who exercise 5 times a week, when they go out and exercise, they're increasing their risk by about 10-fold. If you're a couch potato and you get up and you start to exercise, your risk is about 70 or 80-fold versus you staying on the couch and doing nothing. Now, that doesn't mean that your overall risk and mortality is higher when you exercise, because we know that mortality is improved with exercise, but each bout of exercise does incur some increase in risk. This also occurs in athletes as well, young, healthy individuals. This was physicians, so not necessarily all that healthy, and this is athletes. And so this comes from the Veneto region of Italy, and they're suggesting that the risk of sudden cardiac arrest is 3-fold higher in athletes than it is in non-athletes per exercise episode. All of this comes down to the idea that exercise can serve as a trigger for sudden cardiac arrest in the setting of clinical or subclinical susceptible substrate. So what might that substrate be? Well, first off, the sudden cardiac death in athletes oftentimes is very dramatic, captures headlines, makes the news. These events are rare, though. It happens in males more than females. There may be some biologic differences. There may be some sociologic differences as well. And the types of sports that seem to be where this most occurs is more the burst activities, the start-stop activities, basketball, soccer, and football, more so than the endurance activities. So what are the susceptible substrates here? In young individuals, they really come down to genetic conditions. congenital heart abnormalities, and then some acquired conditions as well. Genetic conditions are the cardiomyopathies, hypertrophic, arrhythmogenic channelopathies, such as long QT syndrome, aortopathies, and Marfan syndrome, which cause aortic dissection. Anomalous coronaries, Wolff-Parkinson-White aortic stenosis. Acquired conditions, coronary artery disease. There's an inflection point about the age of 35. If you're less than 35, your risk of dying of coronary disease during exercise is actually fairly low. Over the age of 35, it increases almost exponentially. So by far the vast majority of sudden cardiac arrest that occurs over the age of 35 is due to coronary artery disease. We get worried about myocarditis in athletes, and then there's this entity called commotio cordis, which is an impact to the front of the chest by a blunt object, which causes a small electrical impulse, which, if performed at the wrong time of the cardiac cycle, can trigger ventricular tachycardia or ventricular fibrillation. If you've ever seen a YouTube video, something like that, it's pretty dramatic how it can happen. This is data from Barry Marin looking at his exercise in the sudden cardiac death registry, suggesting that in this population, which is really gleaned from a lot of media reports and just what gets sent into them, that the number one cause of sudden cardiac death is either hypertrophic cardiomyopathy or unexplained left ventricular hypertrophy, which accounts for about a third of those deaths. I'll point out that anomalous coronary artery tears is another common cause, and then all these other things that we mentioned are sort of a smattering here. The vast majority of these deaths in this population were unexplained. They didn't have any good explanation even when they did autopsy screening. We and others have looked at this in different populations, and we find different results. And I don't want to go over this in too much detail other than showing that this is Barry Marin's registry up here. But if we look at the U.S. military, our NCAA data, United Kingdom data, and in Italy, these distributions vary quite a bit. Nobody's quite replicated the amount of hypertrophic cardiomyopathy in the Barry Marin registry. In the NCAA registry, we only saw a small proportion of ours being caused by hypertrophic cardiomyopathy. There may be some selection bias here because HCM patients may not be able to achieve the exercise performance required to participate at the NCAA level versus Barry Marin's registry, which deals a lot with the high school age population as well. We look at this and tease the NCAA data out a little bit more carefully. This is data provided by our colleagues in sports medicine at, over here at the University of Washington. We see among NCAA athletes over a 10-year period, sort of the breakdown of who is dying and what sort of in terms of sex, race, and sort of athletic performance status. A couple things I wanted to point out here. One is that in general, males are at higher risk. This is deaths per athlete year. Males are at higher risk than female athletes. Blacks are at higher risk than white athletes. And higher division performance tends to be at higher risk than individuals who are at the Division III level. When we tease this out a little bit further, we look specifically at male Division I basketball players. The risk is about 1 in 1,300 over a 4-year period. The risk is higher if you're a black male basketball player. So this also gets teased out a little bit in Barry Marin's registry data, where he's looking at the circumstances of death. Vast majority of the deaths that get reported to him occur in the setting of exercise. Only a small proportion of those in athletes occur at rest. These are largely high school athletes in his registry. That may be because some of the diseases that we're talking about, hypertrophic cardiomyopathy in particular, comes out during the adolescent period, so during puberty when the body's growing, the heart tends to grow, and some of these other conditions come out as well. It's also a time period when your exercise intensity increases substantially. And again, the sports that he saw were primarily basketball and football. Those are also the sports that are most common in our country. So what are we currently doing to reduce the sudden cardiac death risk in our youth? The American Heart Association suggests that cardiovascular screening in this population is justifiable, necessary, and compelling on the basis of ethical, legal, and medical grounds, and they support pre-participation screening for athletes as an important public health issue. So American Heart Association suggests that we should be screening, and the disagreement in this area tends to be largely driven on how we should be screening. American Heart Association came out with a position statement on the use of ECG as a screening test for the detection of cardiovascular disease in healthy populations. And their number one recommendation here is to use the 14-point pre-participation examination, which is the sort of standard of care at this point. When you look at this 14-point pre-participation in screening, it involves taking a personal history for the athlete, a family history of the athlete, and then doing a physical exam. So we're asking in terms of physical history, do they have chest discomfort, syncope, do they have excessive dyspnea on exertion, have they ever had a prior heart murmur, have they had elevated blood pressure, have they had prior restriction from sports, and have they had prior heart testing. If they had answers to that, then it's under the discretion of the provider to determine whether or not additional testing is necessary. It goes on, we look at the family history, early cardiovascular death, disability, family history of any of those conditions, or a little bit of red flags, and then heart murmurs, physical stigmata, Marfan syndrome, and blood pressure is also things they recommend on physical exam. Interesting, they have these largely primary care providers look at femoral pulses as well and try to detect coarctation of the aorta non-invasively, which I think would be quite challenging. But the current, based on this data, there's very little data on the effectiveness of this approach. These pre-participation examinations are largely done by states. They're done by primary care providers. They're required by state schools and teams variably. And when we do this, we're almost looking for this needle in the haystack. These are fairly rare types of conditions that we're looking for. And within that, there's a very high proportion of these athletes and young adults who endure symptoms. So about 50 to 70% of athletes in our registry report one or more positive answer to the PPE evaluation. And then when you look at elite athletes, it's a little bit lower, somewhere between 15 and 45% of elite athletes are going to answer yes to one of the symptoms based on that personal history. So now we're asking the primary care provider to tease out, what is potentially lethal condition from something that is benign based on their physical examination alone. And so there's a lot of barriers in our setup, a lot of barriers between the primary care provider's office and that additional evaluation, some of which is financial, some of which is the fact that they don't have on-site testing. So what more can we do to prevent sudden cardiac death in the youth? Well, there's two real approaches. One is to improve the response to sudden cardiac arrest, and that's improving the sudden cardiac arrest awareness. There's some legislature here in the state of Washington that's required coaches to become more aware of sudden cardiac arrest. They have to do an online training module and to recognize when somebody is actually having a cardiac arrest. And then also to improve the AED availability, like I said, at the close to where the athletic competition is occurring. And then finally, can we identify subclinical disease? And that's really this idea that can we use or should we be using ECG or echocardiogram for advanced screening measures? So this actually is a very hotly debated topic. It's unclear what the right answer is, but a lot of vociferousness on both sides, I should say. And so if you look at this is likely John Dresner over here, and this is Barry Marin over here, and they're sort of yelling back and forth at each other. And if you follow the literature in this area, that's largely what it's become. And so on both sides of this debate here, on the yes side, should we be screening with ECG? Well, they say the current methods are ineffective. We've been doing this pre-participation evaluation for years. It hasn't made a major impact on the incidence of sudden cardiac arrest. We have a tool here, the ECG, that is capable of detecting a lot of these asymptomatic disorders that the pre-participation evaluation misses. But there's a learning curve to doing this, and with time, we're going to get better at this. On the no side, it says these events are rare. They're uncommon. We don't need to be spending the money to do it. There's a high false positive rate. There's some harm that can come with this. We'll talk about that in just a moment. There's financial and non-financial costs, limited resources. We should be spending them in other places. No evidence that it improves mortality. Counter-argument to that is there's no argument that the PPE improves mortality. And then the question is, who should we be screening? Is it ethical to only screen athletes, or should we be screening other individuals as well? We look at these conditions and we separate them out into conditions that are likely detectable, possibly detectable, and not detectable by ECG. This is kind of what we come up with. So hypertrophic cardiomyopathy, unexplained LVH, arrhythmogenic cardiomyopathy, dilated cardiomyopathy, long QT, bravado, and WPW are all likely detectable by ECG. Turns out that 85% to 90% of HCM have an abnormal ECG, regardless of whether or not they're symptomatic or asymptomatic. Possibly detectable aortic stenosis and myocarditis. Myocarditis I put in here. If you happen to catch it at the time they're actively in myocarditis, then you might be able to detect it. That'd be uncommon. And then unlikely detectable, Marfan syndrome, aortopathies, coronary artery disease, and of course commotio cordis, which is a structurally normal heart. We have some data that's in abstract form that's being submitted that when we got some research dollars from the Pac-12 to look at their screening practices, and we compared screening practices among those who did ECG screening and those who did not. And we are showing that there's an eightfold, those programs that screen with an ECG are 8 times more likely to detect an underlying cardiac condition that's capable of causing sudden cardiac arrest compared to those who did not do ECG screening. So I think the more you look, the more you find, and some of the debate is really, should we be looking? There's some cost of ECG screening here. It increases the sensitivity, but it has specificity. There's a lot of overlap here in the ECGs, at least how it's traditionally defined, and changes due to the exercise-induced cardiac remodeling that we talked about. There's the cost of testing, financial costs, human costs, opportunity costs. Should we be spending these costs elsewhere? And then there's the cost of the false positive. If we take somebody and we declare them with disease, or if we say or suspect they have disease, taking them out of the athletic competition, we might be causing some psychological worry. There's additional costs for economic costs, and there may be some health impacts as well. And we have to be conscious of that as we go forward. One of the things that John Dresner and fortunately Jordan Prutkin and myself have been fortunate enough to be able to participate in is the development of new ECG criteria for athletes. And so recognizing all of the athletic remodeling that can occur and how that can impact the ECG. There's been a series of, we hope, improvements in these criteria to try to reduce the false positive rate and try to make the ECG a much better tool, both for evaluation of the symptomatic athlete and also in cardiovascular screening. So in 2013, we brought a sort of an international group here to Seattle, and they proposed something called the Seattle criteria. And in 2017, we published an update to that, and that was also based on work that was done here in Seattle as well. So this international consensus criteria is currently the sort of accepted criteria that's used for international athletes, Olympic athletes and the like. So these new, point out that these new ECG criteria are somewhat data-driven, but they're largely expert consensus. We have our false positive rate now down to probably about 1% to 2%. And unfortunately, we have limited data on the false negative rate with these at this point. These can be automated. We can put them in the ECG machines at the point that we're doing these ECG screenings, and so it takes out the role of the provider a little bit. And so instead of our ECGs calling left ventricular hypertrophy for everything, we're now ignoring that as a criteria, and we're focusing on these other things. This is just an overview about how these ECG criteria look. We divide things into normal ECG findings for athletes, abnormal ECG findings in athletes, and then some borderline findings for which, if there's more than one, we recommend some additional evaluation. So normal ECG findings are really the things that we talked about. It's the left ventricular hypertrophy, it's the bradycardias, it's the increase in vagal tone, things that we think are pretty healthy, normal changes for individuals. So increasing QRS voltage for LVH or RVH, without any repolarization changes. Incomplete right bundle branch block. In fact, right bundle branch block can be very normal in highly trained athletes. ST elevations, and I'll show an example of this in just a little bit. And here, sinus bradycardia, ectopic atrial junctional rhythms, first degree AV block, Mobitz type 1 and type 2, all of which is normal physiology for the trained athlete. So this is what I just wanted to highlight. This looks like if for individuals who aren't used to looking at athlete ECGs, they see something like this right here in lead 3 with this deep T wave inversions that may be concerning. Turns out that this is a black individual This is a very benign and well-documented change due to early repolarization. When these athletes detrain for one reason or another, these go away. And so this, we think, is entirely related to changing, and that is a normal ECG in that situation. So one of the things that comes up is it ethical to only screen athletes, or should we be screening the general population, sort of adolescent population at large? This is data Barry Marin suggests looking at the incidence of sudden cardiac death in non-athletes compared to athletes, and in his estimation here, the risk in non-athletes is higher than it is in athletes themselves, 3 to 1. So the question is, should we be screening non-athletes as well? And I think that's a legitimate point that would also have a lot of implications on how we do it and manpower and everything else that we employ. What both sides of this debate agree on is that the identification of something abnormal or concerning is just the beginning of a long journey. That there's a lot of gray zone evaluations here that are rarely simple. I'll talk about those in just a second. The expertise to do these evaluations should be available whenever you decide to do screening events. You can't just decide to do screening and then not have the downstream ability to evaluate these patients further. And then we have to know the limits of screening. Does not evaluate for all causes of sudden cardiac death. We are unable to detect things like dilated aortas on ECGs. We are unable to prevent commotio cordis doing this. We try to avoid the reassurance that the normal result clears somebody for life, that they're, because of that, they are not at risk of sudden cardiac death, and that's something we have to be wary about. And lastly, the frequency of screening is unknown. This is not a one and done type of thing, and we should probably be screening these individuals again at some point in time. Frequency of that is unknown at this point. So the guidelines that I referred to before kind of put some wiggle room in here, and I put it as a Class 2B recommendation that we can use EKG or echo in addition to H&P in relative small cohorts of young people, aged 12 to 25, not necessarily limited to athletes if there's close physician and provider involvement and sufficient quality control. And so that's given us an opportunity to do some of the things we do. What they don't recommend, and I am in full agreement with, is mass screening, mandatory sort of large-scale screening. We don't have the resources to do that, especially in places, rural America, et cetera, where we just don't have the resources to do this type of thing. The reality, though, is that ECG screening is in place. ECG screening is the standard of care for athletes in Europe. It's standard of care in international sporting events and in U.S. professional sports as well. So it's virtually impossible to get into international sporting event or to professional sports here in the United States without having cardiovascular screening. Over half of Division I athletes undergo cardiovascular screening. Most of them undergo ECG screening, and about 1/4 use echocardiogram as well. And then there's been a lot of sort of public, parental, and institutional interest in this area. Local nonprofits and medical systems filling this void. So just briefly about our UW screening experience here. This started in 2010. We've screened somewhere close to 2,000 UW athletes. We've done some studies of NCAA athletes at large. We've done about 5,000 looking at a multi-site feasibility study using ECGs. We've, as part of our Nick of Time screening program, we've screened over 15,000 high school age students, and then of course we've done some of the professional athletes as well. This is the Nick of Time. We go once a month or so. We go to one of the local area high schools. We set up camp here in their gym. These are the tents right here. Boys on one side, girls on the other, and do ECG on-site screening. These are free and available to all students and not just athletes. Individuals come in, they filled out a questionnaire ahead of time, they get their blood pressure checked, they go get an EKG, they have a visit with the AED representatives, learn how to use an AED, they learn hands-on CPR at the time, and then they come back and they meet with a medical professional to talk about everything. If they have any abnormalities, we have volunteers and individuals, trained sonographers, to do on-site echocardiograms there as well, so hopefully providing an answer. And with that, we think we are providing a service and hopefully doing some good. Screening data here is collected anonymously and stored in a research database, so we're using this for research as well. The abnormalities detected to date, but by far the most common are bicuspid aortic valves and WPW. These are things that we detect at almost every screen we do. We've detected a handful of cases of hypertrophic cardiomyopathy, dilated cardiomyopathy, long QT, congenital heart disease, ASDs, VSDs, anomalous pulmonary venous returns, PDAs, valvular heart disease, including one case of severe AR in which the individual went to surgery within a month, enlarged aortas, coronary anomalies, you name it, we found it, it's out there. And the more you look, the more you find. All of these individuals had standard pre-participation evaluations ahead of time, and all these individuals were missed. And so there's an opportunity, I think, to find things if we want to dedicate the resources to doing that. Our data is actually pretty in line with data that was just published in the New England Journal of Medicine. This is Sanjay Sharma's data looking at his experience in screening English Football Association athletes for over a 20-year period with H&P, physical, ECG, and echo. And they looked at about 11,000 athletes. Vast majority of these were young male athletes. And with this, they found about 2.5% of their athletes had some type of underlying cardiovascular condition. 0.4% or 42 of these individuals had disorders associated with sudden cardiac arrest. About 2% of these had other conditions, bicuspid aortic valves, ASDs, et cetera, the more common things that we see in congenital clinic. And during this period, 20-year, that included variable 20-year follow-up, 8 athletes died with sort of the sudden cardiac arrest death rate of 6.8 per 100,000 person years. 6 of these individuals had normal valuations at the time of the screening, and there's a median about 8 years between the screening and those athletes' deaths. So that's sort of real-life sort of experience with screening. I want to touch base here in the last 5-10 minutes to go over a couple of concepts here in the evaluation of symptomatic athlete and then the management of athletes as well. So symptomatic athlete is somebody who presents, a high-performing athlete starts to develop symptoms. They want somebody who has expertise in this area, and so they come see us in clinic. The most common complaints are chest pain, syncope, palpitation, and reduced exercise performance. And the challenge here is in differentiating a lot of these things which can be very benign from some of the things that can be lethal. When we look at chest pain in the young, we're going to be looking for coronary anomalies. If older individuals, we want to be assessing them for coronary artery disease. The thing about chest pain is also it's very non-cardiac chest pain in an active population is quite common, and so the vast majority of people we see are probably non-cardiac chest pain. Syncope, on the other hand, raises a lot of concerns to individuals. Syncope is common in athletes, and there's something called exercise-associated collapse, which is not uncommon. It's especially seen in our UW, erg, or rowing athletes, nearly all of whom have passed out at some point in time, it seems like. Exercise-associated collapse is due to sort of the cessation, it occurs sort of at the cessation of exercise, and it's due to the fact that our muscles are no longer contracting, our blood pressure is going to drop. We also lose our venous return because the muscles that are responsible, the peripheral muscles that are responsible for getting that blood back into circulation are no longer there. We have venous pooling, all of which creates this situation where we have an acute drop in blood pressure and patients drop. Hyperventilation at this point can also play a role because of the decrease in cerebral perfusion that goes on as well. So exercise-associated collapse is not uncommon. It's probably the most common cause of syncope in this population. But of course, we have to be worried about arrhythmogenic syncope, and that is something that can be very concerning. The red flags for that are any syncope that occurs in the middle of exercise as opposed to the end of exercise, and any syncope that results in bodily injury. So those are the things we look for, and that's more scary and leads to additional evaluation. Palpitations, and then reduced exercise performance is actually one of the most common things we see, and it can be a myriad of different things that influence this. A lot of those are medical, non-cardiac things like anemia, for example. Things from a cardiac standpoint, we want to know about: is there asymptomatic coronary artery disease going on? Is there left ventricular outflow tract obstruction at the left ventricular outflow level or at the mid-ventricular level? Things like that. And so it can be sort of challenging to sort that out. We do stress testing in athletes. athletes, there's a couple of unique sort of things I wanted to talk about. First is that exertional symptoms occurring at the high levels of activity are really challenging. We're not set up to evaluate this in a medical setting very well. We try to recreate the athlete's performance the best we can. So if they're a sprint athlete, we'd like to get them on the treadmill and recreate some of the sprinting that they do. If they're a biker, we try to get them on a bike. If they're a rower, we try to get them on an erg machine. The Center for Sports Medicine actually has a CPET. They have the ability to do erg CPETs over there, so they can do rowing CPETs in addition to the bike and treadmill stuff that we can do here. We exercise to peak capacity. We do not stop at peak heart rate. I encountered one individual who just recently who had a stress test up in Alaska, was stopped at peak heart rate rather than maximal capacity, and it turned out that he had severe left main disease requiring surgery that was undetected because they stopped his exercise at peak heart rate. And finally, we would use a low threshold to use CPAT as a diagnostic test modality. But this is kind of what we get ourselves into, is this idea that somebody presents with symptoms, we do testing. We have to recognize that there's exercise-induced cardiac remodeling. They fall into one of the gray zones, which I'll show on the next slide. That leads to more testing. We go into this cycle. And the idea of the sports cardiologist is to try to get you out of that cycle earlier rather than later. These are the gray zones that occur. This is the athlete's heart, the dilated heart, the hypocontractile heart, the thick heart, and how it overlaps with hypertrophic cardiomyopathy, dilated cardiomyopathy. This is arrhythmogenic right ventricular cardiomyopathy. It can also interact with myocarditis if they have PVCs, and then Marfan syndrome if they're the right body size and have a dilated aorta. So all these things are gray areas within the sports cardiology world, and we hopefully are a little bit better at navigating this as we go forward. The gray zone that has captured the most sort of attention is the gray zone between hypertrophic cardiomyopathy and an athlete's heart. We look at various features to try to differentiate these two. Unusual patterns of hypertrophy, LV cavity dilation here, left ventricular and left atrial enlargement happens for both. Abnormal left ventricular fillings, a diastolic function here, and then exercise performance, and then the gadolinium enhancement on cardiac MRI, certain things we see. You know, the way I sort of approach it, if they have left ventricular hypertrophy, if the hypertrophy is less than 17 millimeters, they have normal ECG, they have concentric hypertrophy, and they have normal diastolic filling. I don't do any additional evaluation. I leave those athletes alone. If they have any red flags, bizarre EKGs, if they've had a syncope in the past, family history, or they have LGE on cardiac MRI, then I think those are concerning findings, and we have to consider HCM. When we talk about sports eligibility, we make a diagnosis in this population, and we're talking about perhaps disqualifying an athlete or having a conversation about disqualification. That can be a really challenging thing. The decisions in this regard are rarely simple. There's multiple stakeholders here. It's not just the athlete that's at stake here. Oftentimes, the family members have a big say in this. The other major stakeholder is the institution or the sporting team that's responsible. They have a say in whether or not the athlete gets to go back to competition. There's a lot of implications for these decisions. Implications can be on career, they can be financial, they can be psychosocial. If you're dealing with an NCAA football player who has professional prospects, for example, you start to evaluate his heart, or label somebody as having a potential heart condition. He can drop in the NFL draft, and you're costing that individual millions of dollars. So these are not simple sorts of things that have to navigate. There's some legal considerations here as well. American Heart Association, American College of Cardiology come out with these eligibility with disqualification recommendations. They're available. They used to be called the Bethesda Guidelines. They've been updated in 2015. They're still very conservative compared to what the general practice is. There is a little more wiggle room here for individuals who have implantable cardiac defibrillators. We think they're protected. The Sport ICD Registry has offered us a little bit more reassurance that those athletes are protected. We consider disqualification only if there's definite or probable disease. If you're unsure about the diagnosis, those individuals get to continue to participate. This is a big decision for them, and be sure about the diagnosis before you go launching down that. There's been a lot of growing acceptance of this shared decision-making model, and I think that's the right approach. I think it's more challenging. It's much easier for you to say, stand up and tell somebody they can't do something because the discussion's a lot shorter than this shared decision-making, which makes sure really having to tell somebody that and reassure yourself that you have a really, truly informed patient. So you have somebody who comes in, they're a professional athlete, maybe they're an amateur athlete on a scholarship, they get diagnosed with a disease that puts them at risk of sudden cardiac arrest, and you start to have that conversation with them. They put a lot into this, right? Their entire life has been around this athletic competition, and now you're telling them that they can't or shouldn't do that. And there's a lot tied up in that initial sort of shock and all of this, and you have to navigate this. Time helps. Having second opinions helps. Having that athlete hear it from more than one individual, I think, has merit. But what we don't want to do is encourage doctor shopping. We don't want them to go around, try to find the doctor that disagrees with you, or until they get a doctor that they like the answer to, and they can go forward with that. So lastly, just briefly, I think there are 2 slides left here, the management of athletes with cardiovascular disease. Just want to talk about 2 topics. One is cardiovascular coronary artery disease in athletes, some of the unique aspects of this. And we know that coronary artery disease is the most common cause of sudden cardiac death in athletes over the age of 35. And it's surprisingly with how prevalent the risk factors for coronary artery disease are in this population. I think that's in part driven by the fact that if in earlier life you smoked, you lived a less than ideal sort of cardiovascular fitness life, then you're engaging in exercise to try to make up for everything that you did earlier. The other is that there's some observational data here that suggests that intensive exercise training increases the mortality risk in patients with known coronary artery disease, particularly in individuals greater than 60 years of age. It raises the specter of this idea about silent ischemia. And whether or not that is cause for sudden cardiac arrest in this population. And because of that worry, because we may be less likely to treat medically and more likely to treat interventionally, the symptoms are different in athletes. The symptoms of angina often are warm-up angina. I have classic chest pain, pressure sensation when I first start to exercise, but it goes away later in exercise. And a lot of people are just going to dismiss that. Well, in fact, that's ischemic preconditioning is essentially what's happening, is that they're getting tolerant to it and they're pushing through it, and then they don't no longer have the pain, even though they're still having some ischemia. So medical therapy is often poorly tolerated in this population. They don't like beta blockers. The statins make their muscles hurt, et cetera. So medical therapy is very challenging here. One thing I want to emphasize is if they've had an acute coronary syndrome event, really important for them to prioritize medical therapy, even if it means cutting back on their exercise to do so. And I think it's a conversation that a lot of athletes don't want to hear. So secondly, atrial fibrillation. Atrial fibrillation is more common in athletes than it is in the general population. It's mostly seen in masters and endurance athletes, individuals who participated in endurance activity for long periods of time. They have left atrial remodeling, structural remodeling, and they may have some inflammation and fibrosis as well. This is data from this is the best data we have. This is the Vasaloppet. This is a Nordic cross-country skiing event, and they looked at their population, which is like 50,000 athletes or something like that, and they looked at the time and the cumulative. Here it is, the finishing time group, and this is the number of races. So this is how quickly you're finishing, and this is the number of races that you've finished. We look at the people who are a little bit faster have higher risk of atrial fibrillation, and those individuals who've done more races have a higher risk of atrial fibrillation as well. So the atrial fibrillation does increase left atrial size, and with that likely increases your risk of atrial fibrillation. Medications, again, similar to the coronary artery disease group, are fairly poorly tolerated. People are much more likely to want to pursue AFib ablation strategies. But fortunately, the CHA2DS2-VASc score in this population is usually quite low. We don't have to invoke anticoagulation as often. So we're going to talk, just finish up here with some conclusions. Sports cardiology is an emerging field dedicated to the care of patients who engage in sports and higher level activity. The key here, the art of this, is the understanding the dose-response relationship between the amount of exercise somebody does and the amount of sort of chamber and cardiac enlargement that we're seeing. Underlying conditions, we have to understand the underlying conditions capable of causing sudden cardiac arrest and the management of these athletes. I'll also point out that screening for sudden cardiac arrest in athletes is becoming increasingly common. We think that ECG may be useful adjunct, and the University of Washington has contributed some to that area. And then lastly, and something I didn't have time to talk about, is this idea of there's some controversy about whether too much exercise it can be harmful, particularly in regard to arrhythmogenic right ventricular cardiomyopathy and or the development of coronary artery disease. So thank you very much. I appreciate your time. I hope that was a decent overview of what sports cardiology is. I want to thank some of my colleagues over at the sports medicine group and the individuals who make up the Center for Sports Cardiology here: John Dresner, Kim Harmon, Hank Pelto, Jordan, Jack Salerno over at Children's, and Monica Zigman, who's our research statistician. Thank you very much. Okay. All right. Does anybody have any questions? Catherine?
Fantastic talk. I mean, a great overview considered large business. Since I know that problem was that a lot of the data you presented is really the male athletes, and even like that last slide, the risk of AFib and the risk of overconditioning, as far as I know, it's all male athletes, and there's no way that that's true. Is that correct?
Absolutely. Yeah, I think that is definitely one of the. Yeah, absolutely. Let's go, Jeff.
David, you flashed the thing for guidelines up a couple of times from circulation.
Yep.
What year, please?
The guidelines for the ECG, I think, were 2015. They're fairly recent.
I'm having trouble figuring out why some of the trained athletes had an ejection fraction that was low. Is there any explanation for that, how that happens, and why it's not an issue for them?
Well, if you think about it as sort of a stroke volume or cardiac output being maintained, if you have a large ventricle, you need less of an ejection fraction of that ventricle to maintain the same stroke volume. And so I think that's the rationale for that. We look at ejection fraction as an imperfect measure of cardiac function. Stroke volume is normal in these individuals because of the larger left ventricle.
Really, really great talk, David. In the screening study in the tents in the gym,
yep.
I imagine there's a lot of false positives that we get weeded out later on, and there's obviously a potential cost associated, lots of costs.
Yep.
You can outline that. Are you guys looking at that?
We do a lot of things, I think, to try to reduce the false positive rate, and I think that the number of individuals that we refer for potential false positives is low. The fact that we have trained sonographers on site to do our echocardiograms, I think, is really the reason for that. And we've been lucky enough to UW Medicine and previously Seattle Children's Hospital have been supporting us in this effort. They pay for the sonographers to come. We have sonographers who volunteer their time as well. But I think that really is limited. So on an average screen, things like bicuspid aortic valves, WPW patterns, things like that, those are the most common things we pick up. We'll pick up and refer maybe 4 or 5 patients or 1% of the population for further testing, which I think is on par with other things. The limitation to high school screening thing is that we don't have very good information on what happens after the screen. I'll admit that because of HIPAA things, we don't have access to what happens after the fact, other than individuals who've then come back to us and reported on their experience. Great.
Great talk, David. I thought the British data was very fascinating. 20 years of cost, 42 people in individualized stuff, and 6 people or 8 people still have cardiac death. Isn't that the argument that maybe there is correct?
Yeah, no, I think it comes down to a societal perspective on this, and I think what it comes down to is the more you look, the more you find. You use ECG, you find more. You use echo, you find even more. But there is cost associated with it, and then it comes down to the economic cost. Is that something that you really want to be spending your time and money doing? And that, I think, comes down to a societal perspective. I think Europe's very much in favor of this. So this is a British study, and I think people in England are very much in favor of this. This is they have a national healthcare system that's very different than what we have. The other aspect of this is if you look at cardiovascular screening as simply as a way to reduce sudden cardiac arrest, I think it's somewhat a narrow focus. I think we also have to look at the those individuals who we identify with other forms of heart disease, the ASDs that we detect early, the bicuspid aortic valves that we detect early, the WPWs that we detect early, and maybe there's some benefit in that as well. And that's hard to sort of, the benefits of that are really hard to calculate. So, Karen.
Somebody else also talk. Just the cost thing though is there is no cost for doing time. Those are free screens. And so if you really were bent on doing the echo component of it, which is one of the ways to get away from false positives, you're not adding ECG, you then have to deal with consequences, as I have multiple people in my clinic that they will start and having an almost like one and off the left, straight in this then you're kind of stuck with somebody with a cardiac disease you're certain on. But arguably, if you were bent on doing it, you can reduce costs with handling that. But David, one of the things that I've really appreciated about clinical care that you provide is that you really focus in on what people can do rather than do. And when I reviewed those guidelines and they came out, it seemed like they're shifting a bit farther away from you have to think hard to do that, anything, to being a bit more, let us figure out what we can do. Do you want to expand on that at all, or thoughts or some change that's coming in regards to the value of exercise and kind of opportunities for safe exercise?
Yeah, I think those are valid points. I felt like I didn't have time to cover all of that here, so we didn't delve into it a whole lot. And that, I mean, I deal with this idea about counseling patients with hypertrophic cardiomyopathy and how much that exercise is beneficial, how it can be harmful, just about every day. I see patients, and there is some growing data about the benefits of exercise in this population. I think some of that. I think we dichotomize things. We talk about the diseased heart and the healthy heart, and as if they're almost separate. But in fact, the diseased heart can undergo exercise-induced cardiac remodeling. We know that. There can be beneficial effects. Increasing the left ventricular chamber size can be beneficial in patients with HCM. It allows them to exercise more, prevents intracardiac obstruction. But we have to balance those against the risk of sudden cardiac arrest. They're challenging discussions. I agree. I think we're moving away from a paternalistic approach where we diagnose and exclude to an approach where we diagnose, we counsel, and we work with that patient to find an acceptable level of exercise. We've seen patients here who have gone on to have ICDs, and they're playing in March Madness basketball tournaments at the NCAA Division I level. We've seen soccer players here where we've continued to allow them to exercise soccer players with hypertrophic cardiomyopathy. We've encouraged them to continue to exercise and encouraged to play competitive soccer. And so I think we're moving away from the idea that we need to diagnose and exclude to the idea that we need to diagnose and work with that individual. Thank you for that. Okay. Thank you very much, everyone. Appreciate the time.